From the Heart.org Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Arthur L. Bloomfield Professor and Chair of Medicine at Stanford University.
Hi, this is Bob Harrington from Stanford University on Medscape Cardiology and the Heart.org. This is the second part of a series of conversations that Mike Gibson and I have been having around what's been going on in cardiovascular medicine during 2020. In the first episode, we talked about all the non-COVID related issues and really concluded, wow, the science is really moving forward. We learned some important things in antithrombotic therapy and lipid management, and maybe in particular in heart failure. Now, Mike, I want to talk about COVID, and maybe COVID from the perspective of a cardiologist. And I'll break our conversation down maybe into 4 or 5 areas, one of which is the early signals we got out of China and then from Italy around the increased risk of cardiovascular patients and their outcomes of COVID. Second was this increase in thrombotic events, myocardial infarction, stroke, that then has set off the search for antithrombotic therapies that might be beneficial. Third is this whole issue of myocarditis. Fourth is I'll call it the unintended consequences. People didn't come to the hospital because they were scared. And so therefore MI presentations dropped, stroke presentations dropped. And then the final topic will be just lessons generally learned. And you and I, as clinical researchers, are particularly interested in some of the research issues that were learned. So with that, my guest, Mike Gibson from Harvard Medical School, where he's a professor of medicine, the Beth Israel Deaconess Medical Center in Boston, where he's an interventional cardiologist. Mike is the director and CEO of the BAME Institute, an academic research organization, and a longtime friend, collaborator, and colleague. Thanks for joining us, Mike, on Medscape Cardiology.
Well, we're here now for our COVIDologist segment rather than our cardiologist segment. Right?
Yes, it's been quite the year. So let's back up, Mike, to February, March. This viral pandemic is hitting. Early reports out of China were that patients who had cardiovascular risk, hypertension, heart failure, coronary disease, diabetes, seemed to be at an increased risk of both getting the infection and doing worse with the infection. Raised all sorts of questions about ACE inhibitors, ARBs, maybe the virus was entering the cell we know the virus enters the cell through the ACE2 receptor, so therefore were ACE inhibitors bad? Those early days, what were you thinking and how do you now put it together? Because we've learned a ton since February, March.
It was a riddle wrapped in an enigma that was a mystery that was topped in secret sauce. I mean, it was so confusing. And, we had all this observational data and, you're talking about risk factors. Well, is it really the hypertension that's a risk factor? Or is it the fact that you're on an ACE or an ARB that's really mediating the adverse outcome? So we had a plethora of observational data, but we really didn't have the science behind it to begin to nail down all these kind of causal pathways. And we still have a lot to learn. Today, Bob, there was a fascinating article about identical twins, and they were both 60, 2 males, and they both contracted the same strain of the virus from the same person. One got severely ill, and the other one didn't. And it raises questions, is it genetics? Well, boy, these are, identical twins. Is it environment? Well, they had the same environmental exposures. They lived near each other, had similar jobs. Is it all those chronic risk factors you mentioned? Well, no, they both had similar, blood pressure and diabetes and all that. And it makes you scratch your head about what really is mediating a lot of this. And, makes me wonder, is some of this immune priming from different exposures to different coronaviruses, perhaps? So I still think it's quite a bit of a mystery.
Yeah, and certainly I know that back in the spring from a American Heart Association perspective, we were being called on to answer the question, should patients stop their ACE inhibitors, the ARBs? And early on, we said there's no evidence that you should stay on those drugs. The consequences could be worse. Fortunately, as you've said, the observational data suggested that The drugs themselves were not problematic. And then kudos to our friend Renato Lopez and the Brazilians who actually did a randomized trial. uh,
Absolutely.
and,
Break
and-
Corona. Yeah.
yeah, and helped us really show that it wasn't a problem.
Absolutely. No, I was part of their team and we randomized people to continuation versus discontinuation of
Yep.
ARBs and saw no difference in outcomes. So kudos to them. One of the biggest failures was the lack of organization in our country. One of the biggest successes was the unparalleled organization in places like Brazil and Renato and others leading the way there. And in the UK, I mean, they just simply beat the pants off us. It was amazing.
Yeah, the UK, our good friend Martin Landry actually posted today that they have gone over 20,000 patients randomized at only 174 sites in the recovery platform. So I agree with you, Mike. That's going to be one of the lessons I want to come back to, as
Yeah.
to what did we learn and what can we do better. Second topic, the early on, we also began to see myocardial infarctions and strokes. And again, learning from our colleagues that were really getting inundated with the disease, started treating people with antithrombotic therapy. Now, the challenge is that nobody was quite sure, well, is this prophylactic antithrombotic therapy? Is it therapeutic antithrombotic therapy? We're seeing arterial thrombosis, but we're also seeing venous thrombosis, VTE and PE. How do you put all that together now? I mean, my opinion is we still don't know. Judy Hockman's leading an NIH trial, which is comparing prophylactic versus therapeutic doses of anticoagulants in the hospital. But around the country, Mike, I know, because I've been involved with that trial, that people are doing really different things.
Yeah. Well, yeah, you tell 1,000 doctors what to do or ask them what they're doing, they're probably doing 2,000 different things. So it's quite variable. Bob, I was very, very confused by all this. At the beginning, it wasn't clear, was this DIC? And, when you look back at the early Chinese reports, they applied the ISTH definitions, and they said in 70% of their cases in China, they said it was DIC when they looked at autopsy studies. So I thought, well, if it is DIC, maybe all these antiplatelets and antithrombins are not going to be that effective. But the story changed a bit, and now it obviously looks like there's probably a diffuse endotheliitis that is activating the clotting cascade. And, probably all the complement that's getting released also is activating the clotting cascade. So yes, we can give a lot of these drugs. You do wonder if we work our way proximally and reduce some of the inflammatory response, if we could downwardly attenuate the need for some of these drugs, which do cause bleeding. But as someone who, like you, I worked with you on a medical prophylaxis trial. Wow, now's the time to really kind of roll out those drugs and see if we can prevent some of those pulmonary emboli.
Yeah, so now there's three great trials going on, again, sponsored by NHLBI. One is our mutual colleague, Paul Ritker, who's looking upstream to your point, trying to identify people who are at high risk by elevated biomarkers, and then randomizing to a variety of approaches, including placebo, against antithrombotic therapy. Dr. Hockman's trial, which is inpatient, and then our former colleagues at Duke, led by Tom Ortel, Tracy Wang, are looking in the outpatient setting. This is where you and I have done a lot of work,
Mhm.
because there's no question, if you've had heightened thrombotic risk, when you leave the hospital, at least for another month to 6 weeks, you still have heightened thrombotic risk that can be attenuated in the case of the project you and I worked on by by Betrixaban, a factor 10 inhibitor. So stay
Yeah.
tuned.
Stay tuned. If I was sick and I'm just talking about me, I would probably want to get prophylaxed. And, every patient's different. Every patient, you got to look at the risk and the benefit. But I think overall, I would lean a little more towards, in general practice, a little more towards prophylaxis.
Yeah, it'll be interesting. We'll see what the trials show us. And in the meantime, let's keep investigating the science. Some great papers on this topic from your Boston Brigham colleague, Peter Libby, on looking at the endothelial damage
Yes.
and trying to help us understand why the clotting occurs. Let's move from the vessel, Mike, to the muscle.
Mm.
Over the summer, series of reports came out showing the relationship between infection and abnormal signals on cardiac MRI suggesting myocarditis. And then a couple of things happen, one of which is some well-known athletes, including there in Boston, one of the Red Sox starting pitchers, Eduardo Rodriguez, gets pulled from the season because he has myocarditis following COVID, and sounds like he was symptomatic. And then the second is a group from Ohio State University published a series of MRIs on athletes who have recovered from COVID, again, showing high rates of signal on MRI. What did you make of it at the time? And then we'll talk about where we are today.
Well, at the time, I found it very concerning, and it really got my attention. There were some criticisms of those studies, but where there's, where there's some smoke, there's probably some fire. I think there really is cardiac involvement. I'm not personally quite sure the magnitude at this point. I'd like to see some more data. But one area that was really confusing to me, and the lay press confused this quite a bit, was saying that the virus was infecting the heart. And, I got really annoyed reading that. When you really looked at it, it was the virus was in macrophages around the myocytes, not in the myocyte itself, for quite a long time. And then some studies did come along and did seem to indicate there may be some viral particles inside the myocytes themselves. Nonetheless, it all added a lot of confusion when you're in the emergency room. You have someone with chest pain and elevated biomarkers who's COVID positive. Are they having a STEMI? Or are they having myopericarditis or Takotsubo's? Or, it was a very, very complicated picture.
Yeah, and I would say, Mike, I think it's still complicated. That
Yeah,
some of the follow-up pathology studies have shown that, well, there's not that much true pathologically defined myocarditis, certainly less than would have been suggested by MRI.
right.
As you know, Mike Bristow at Colorado funded through AHA to actually look at myocardial samples
Mhm.
in people with COVID. So I think there's still more to come. The myocarditis does not look to be as common as the imaging might have indicated. But I'll tell you that trying to figure out what to do with competitive athletes is tricky, isn't it?
It's really tricky. I grew up in Boston here in that area where we had, some pro athletes die, with a lot of controversy about should they be out there. I think until this is settled, I would urge people to be cautious at this point.
Yes, a couple great papers in JAMA Cardiology a few weeks ago, including from one of your Tufts colleagues, Jim Udelson, to really try to frame up how to look at this myocarditis and competitive sports issues worth people taking a look at.
I know,
Uh,
Bob. I know I'm not going to get out on the court or on the football field. I'm going to stay put.
Despite the fact that you are a retired running back, if I remember, from University of Chicago.
Yes, starting halfback, University of Chicago, but I'm going to stay on the couch.
Can you give me that Heisman pose? There you go. All right. Unintended consequences. Certainly, I was hearing from colleagues, mainly in places that were getting hit hard, like Boston and New York, that during the height of the pandemic, you were seeing less cases of ST elevation MI, less cases of acute stroke. That was observational. And then the national data started showing fewer 911 calls for evaluation of acute chest pain, acute stroke symptoms. And it does look as though there were fewer MIs presenting. Now, the pullback of that was that, well, people were afraid to go to the hospital. And then we started hearing, I heard from one of our surgeons here, he said, I've done a couple of cases of ventricular septal rupture repair in
Yeah.
MI patients that I haven't done in years because of rapid reperfusion, but now these people are presenting late. So take all of that, Mike, that I'll call as the unintended consequences. You were in the middle of it in Boston. Was
What's
there some truth to all of this?
Yeah, yeah. Back in the 90s, we had patency rates that were 15 to 20% on arrival to the cath lab, mostly closed arteries. What's interesting is over the past 20, 30 years, those numbers have crept up to 35, 45%. There's something going on. I think personally that as people are getting there a little quicker and they have less mature clot, and the drugs we're giving them are reestablishing patency a little early. Fast forward now to this pandemic, and everything goes the opposite way. People are waiting at home, scared to go in, scared they're going to get COVID. They fear COVID more than they fear an MI, and you know, they just had the complications that you said. We saw all that in Boston. We saw about a 50% drop, and that was true around the world. Italy reported a 50% drop, and everyone reported more mechanical complications. It was kind of interesting at one time to see people starting to talk about giving lytics,
Yeah.
but you know, and I was waiting on the calls because I'm probably the only person who knows how to give a lytic in our hospital these days. But
Well, I was thinking the same thing. I said, there's not many of us who gave a lot of thrombolysis, but there are still some of us.
yes, yeah, exactly. So, but it turned out primary angioplasty is probably the way to go.
Yeah.
Uh, and we're back on our feet. Our volume's at 80% of where it was. We aren't closing down. We're just going to continue to go now.
Last topic, lessons learned. Maybe from a research perspective. We had sort of addressed it in our last session. Research has kept going, certainly from a COVID perspective. Wow, the amount of papers that have come out, lot not very good, some really helpful. What have you learned, Mike?
Ooh, man, I think there's so many lessons learned. One is you only have one chance to make a first impression. And sadly, I think science and public health made a bad first impression. You know, we heard that no, you can travel. No, you don't need to wear a mask. No, it's not aerosolized. It's by contact. And when they began to change their recommendations, people got really scared. You know why? Because people love predictability. They absolutely loathe uncertainty. And we really laid down a lot of uncertainty for the public early on. Now, you and I are scientists. We like to think we are. And we welcome uncertainty in testing this out. But the public does not welcome certainty. I think that's one of our biggest limitations. And then when you have that uncertainty, I think people from all sides rushed in from all sides of the political spectrum to offer the answers, to offer certainty. And even though we all knew there was no certainty. And here was the saddest thing: storytellers prevailed over scientists. You know, sadly, emotional connections and tribalism really sadly prevailed over science. Now, mercifully, the scientists kept going, and mercifully, the scientists have developed a lot of treatments to be effective here. But I think we went through a period which was some of the worst I've seen in science in terms of bias, in terms of confirmation bias, in terms of people only believing the data that supported their presumptions and their own kind of biased viewpoints. So I don't know, Bob. I hope that with the success of the vaccines, with the final triumph of science in combating this thing, I hope scientists and public health officials can regain their voice so that we can establish science and the scientific approach as a trustworthy way of getting through these things. And I hope we've taught people about uncertainty and about how you answer uncertainty, and it's not through the narratives that we saw.
Yeah, no, Mike, I could not agree with you more. I think that for scientists like you and I, we welcome things changing because that means we're learning and we're adapting and we're testing new hypotheses. But we didn't have consistent messaging throughout. And I think the challenge of science literacy in the public is makes this difficult. That people don't accept uncertainty as something that we really want to do. And so I'm with you. I think that we've learned some important lessons on how one thinks about science, how one transmits science, how one communicates science, and we got some work to do.
We have a lot of work to do. And, you and I are both leaders. We both have difficult challenges. I had to turn a bankrupt organization around. And you know what? People want two things from you, and they want them simultaneously. They want speed and they want accuracy. And it's a little bit like the Heisenberg uncertainty principle, which is often misstated. The real Heisenberg uncertainty principle is you can't know both the location and the speed of something at the same time. As it applies to politics, you can't really have accuracy and speed at the same time. And we do our best to reach a compromise between those two. But if you win on accuracy, well, you were too slow. If you're quick, well, then you were inaccurate. And, it's just a tough job. I mean, I really felt for all the public health officials, everyone trying to lead us through this pandemic. It was a big challenge.
It was a huge challenge, and I think that there are some important lessons learned. We got to do a better job of how do we convey science. I think we got to do a better job of how we talk about science, how we teach science, what our expectations in the schools ought to be, and still a lot to learn.
I think in
Well,
medical school, we need to do a lot of work teaching people about observational data and its limitations.
absolutely. Well,
Yeah.
Mike, I want to thank you for joining me here on Medscape Cardiology, the Heart.org. This has been a fascinating series of discussions today. My guest, Mike Gibson, professor of medicine at Harvard Medical School, Beth Israel Deaconess Medical Center in Boston, and the BAME Institute. Mike, thanks for joining me here.
Thanks for having me, Bob. Let's have a better 2021.